The complete unilateral cleft lip and vomerine flap closure, which you're about to see, is actually done using this operating microscope as a way of obtaining the picture. We don't usually use the microscope for doing lip repairs because you do need a more three-dimensional view of what you're operating on, but it gives a good, clear picture of the repair. We do use the microscope for palate repairs and pharyngoplasties. The technique that you will see is an amalgamation of many other surgeons. There are many influences. It's not very little of it is my own, but it's the collection of procedures which I've adopted and currently use in 2006. This is a 3-month-old baby who had a complete unilateral cleft of lip and palate, including the alveolus, on the right side. The rest of this video is going to show the upside down view of this baby. In other words, the view of the surgeon sitting at the head of the table. So this is this little boy. You'll notice the prominence in the floor of the nose, which is actually, as you'll see in a moment, a tooth. This is a fairly standard complete unilateral cleft, and that's a natal tooth. This procedure has actually been carried out using an operating microscope to obtain the pictures. There's the tooth, presumably a deciduous lateral incisor. So the pictures are being taken through the microscope. I don't actually use a microscope routinely for repairing a cleft lip. I do for repairing a palate. So we've now put some of the marks on. The left apex of Cupid's bow, the middle and the right, using a nib pen for marking. And this is basically a modified Millard repair with a small triangular flap at the lower end. And then drawing in the C flap, which will form the nostril sill. And that's the small inset for the very small triangular flap. It's not really a Randall Tennyson, it's a small triangular flap, which will just break up the straight line of the scar. I've also marked there the wet-dry junction. Laterally, I base the positioning of the vermilion margin point on the length that's required for the repair. I don't measure because I think it's very easy to distort measurements anyway. And I don't base the decision on where the white roll ends up because the white roll is very variable. Here, for example, the white roll goes a long way towards the base of the nose, and if you made the point at the end of the white roll, you'd have a lip which is too short. That's the very small triangular flap at the lower end. And I tend to be fairly moderately radical about how much mucosa I take away, probably more than many people. The reason for that is in the technique which I use for closing the muscle, for repairing the muscle, which you'll see later. And then extending that incision around, that natal tooth somewhat obscures the view, but extending the incision around on the side of the premaxilla, which will become continuous with an incision at the junction of vomer and palatal mucosa. Laterally, the incision goes down on the side of the alveolus, and then there's a lateral sulcus incision on the cheek side of the sulcus. In other words, not too close to the attached gingiva. And then a modified gag. This is a modified Dott-Kilner gag, which we've modified for use with the operating microscope. And there's the palatal cleft. Vomer attached to the greater segment on the left of the cleft. We're going to use a vomerine flap for single layered closure of the hard palate. So the incision begins as the vomer disappears towards the skull base, then at the junction of the pink vomerine mucosa and the pale palatal mucosa, and then coming around anteriorly to become continuous with the incision on the side of the premaxilla. On the lesser segment lateral side, the incision passes along at the junction of the oral and nasal mucosa, at the margin of the cleft, and extending in the soft palate just a little way into the soft palate, at a point which will be re-incised when we repair the soft palate. The incision that you can see going around the maxilla, the lesser segment, becomes continuous with that incision along the edge of the cleft. So this is the technique which I think was first described by Pichler, the vomerine flap closure, and then I think popularized by Mackinder, but particularly the Oslo team. We've now put some local anesthetic in the lip and waited a few minutes for it to work. The local anesthetic is 0.5% lignocaine and 1 in 200,000 adrenaline. And now we're making the incisions. Little cutback for the triangular flap from the lateral segment, sacrificing a little bit of that mucocutaneous junction. There's the incision going around just above the natal tooth, which we have removed, by the way. That's just the mucosa surrounding it, as it was obviously mobile and of no use. And then just mobilizing the C-flap a little at this stage and excising that ellipse or teardrop shaped segment of mucosa, mucocutaneous junction. Most of this dissection is done with a knife. I almost never use scissors for cutting. Then the lateral segment, beginning inferiorly with that cut, and defining the little triangular flap, and then an incision upwards and into that crease in the alar base. Many now avoid the lateral incision. I make it short, partly because I need somewhere to inset the small C-flap, and because it gives me better exposure to the alar base. But it's certainly not, it doesn't extend it around the alar base as has been done in the past, often producing a rather poor scar. And again, sacrificing a certain amount of that marginal mucosa. And usually starting a bit of bleeding, which is controlled with the bipolar. So that this technique is really a combination of many techniques and a few of my own. It's partly inspired, of course, by Millard, by Tennyson, Peter Randall, by Hans Andel, by Harold McComb, by a lot of, there's a lot of input from a lot of ideas from many other surgeons. And that's just demonstrating where the sulcus incision will be. I tend to do the sulcus incision and the subperiosteal undermining of the maxillary periosteum early on, before going back to do the vomerine flap. Just extending that incision around the piriform aperture. Obviously making sure that the tooth buds are not damaged. And then an incision in the sulcus, or on the cheek side, the buccal side of the sulcus, leaving a good fringe of mucosa at that point and not being too close to the gingival margin. And that incision is going through periosteum. This is partly inspired by Tord Skoog, who popularized periosteal flaps, but I'm not actually raising a periosteal flap here, partly by Hans Andel. There's an ongoing debate about whether dissection should be subperiosteal or supraperiosteal. I personally believe that subperiosteal dissection is a much more natural plane, and in other parts of the body it doesn't cause problems. But more importantly, there is the potential for new bone formation, which I believe happens here, thus providing a better bony support for the alar base. You do need to be careful here. The tooth buds are not far away, the bone's very thin, the rudimentary sinus is also not far away, so that getting into that subperiosteal plane inferiorly needs to be done with great care, not to damage the bone. So now the guide goes back in. Undoubtedly, one of the downsides of the vomerine flap is the oozing, both at operation and afterwards. We've found that using tranexamic acid seems to reduce that significantly, although we haven't yet measured it. But before we began using tranexamic acid, in a series of about 160 vomerine flaps at lip repair, about 4 bled, and I think and had to go back to theatre. So it is one of the downsides of this procedure. So now the incision. Note, by the way, the use of the barren handle, which makes it much easier to make these sort of curved incisions. And here using left hand to make the incision along the vomerine crest as it goes up towards skull base, because getting the angle right is at that posterior part is difficult with using the right hand. And then an incision at the junction of the oral mucoperiosteum and the vomerine mucosa. Continuing around on the side of the premaxilla, slightly obscured here by the remnants of the mucosa around that tooth, but that incision usually goes on the oral side or inferior to a groove in the vomer, which is fairly uniformly present in a complete cleft. So on the oral side of it, which means that you have, if you put it in that groove, you have limited vomerine mucosa. But also, I suspect that that's the correct place to do it anatomically. So using the 69 angled beaver blade to make that incision around the side of the premaxilla. And that incision then becomes continuous with the lateral incision in the C-flap of the lip. Just continuing the dissection posteriorly along the crest of the vomer up to where the vomer joins the back of the hard palate. And then again using the 69 blade of the beaver to make the incision at the junction of the oral and nasal mucosa right on the edge of the cleft. That way you preserve all of the oral mucosa, which I think is the really precious material here. If you try and make that incision with an ordinary knife, the tendency is to place the incision around on the oral side and therefore sacrifice some oral mucosa. So the incision's made just at the edge, and with the beaver you can feel the bony edge. Now beginning to elevate that vomerine flap in a subperiosteal and more anteriorly a subperichondrial plane, using a dental scaler, Mitchell's trimmer, whatever you like to call it. And once you're in a subperiosteal plane, it's fairly easy to just continue that forwards. Obviously not quite free at the crest of the vomer. I was a late convert to the vomerine flap technique. I had believed the story of the vomer being important for growth and that you shouldn't touch it, but became convinced by the growth outcomes of the Norwegian team, where this technique has been used for a long time, and the Oslo team, and decided in 1993 that without good data of my own I really should convert to it. Prior to that I had largely performed Langenbeck flaps. So I started the single-layered vomerine flap closure of the hard palate at the time of lip repair in 1993. Again, with care, elevating the mucoperiosteum on the cleft side, on the lateral side, using a dental scaler, and elevating it for 3, 4, 5 millimeters, something like that. Because the crucial thing about the vomerine flap technique is overlap, is inserting the vomerine flap under that oral mucoperiosteum so that it's a double-breasted overlapping repair. Colleagues who've used the same technique but sutured to the nasal layer of the lesser segment, which is the logical place to put it, have had problems with it breaking down. And I think being a single layered closure, the overlap is really critical. A little further back, where at the beginning at the front end of the soft palate, the incision again follows the line of the junction between the oral and nasal mucosa, and you get down to bone and usually elevate some of the mucous glands from the depression at the back of the hard palate, where there's often some dimpling on the oral side of the palate. So just lifting that mucoperiosteal flap enough to be able to put the ovomarine flap underneath it. And going back just as far as is sensible, obviously not very far back into the soft palate, and as far back as you need to make full use of the vomarine flap. Now we're removing having removed the gag, continuing that elevation of the periosteum from the anterior maxilla, and that carries on up to the level of the infraorbital nerve, which is fairly clearly seen. Once you get above the tooth bud area, the maxilla is fairly solid and not easy to damage. And then around the piriform aperture, it continuous with the incision we've made at the junction of the oral and nasal layer and the incision around the edge of the alveolus, so that we can then elevate the lateral nasal wall and the nasal surface of the hard palate. And that dissection carries on up to the inferior turbinate. When there's a significant anterior-posterior discrepancy, as in this case where the alar base is posteriorly positioned, I then divide that lateral nasal wall and nasal floor at a point about a centimetre or so behind the piriform aperture, because I think it's the only way that you can elevate the alar base and put the alar base in a reasonable position. So this is using a pair of Stilly scissors, dividing the nasal floor, the lateral nasal wall, and in this case also the turbinate at that point, about a centimetre, perhaps a little bit more behind, but not so far behind that there's a danger of damaging the nasolacrimal duct. Having divided that, it becomes easier to continue the elevation of the periosteum of the anterior maxilla. A little bit more freeing of that dividing of that lateral nasal wall and turbinate. And I, as suggested by Hans Andel, use the turbinate as a little bone graft, for what it's worth, at the alar base at the end of the procedure. Not sure whether it encourages bone growth or not, but I think this technique does improve the symmetry at the maxilla at the point of the alar base. A little bit further release of that lateral nasal wall. I think you saw it give then. And as that vertical, so it's a vertical incision basically in the lateral nasal wall, and as that continues superiorly, I aim to the piriform aperture, so that at its top end that incision is about level with the piriform aperture, as you can see there. And that's a little bit of turbinate that you can see, taking a bit of the bone out of the turbinate. In this case, probably not a very large piece. Sometimes it's bigger than that. I keep that. I put it just as a little onlay on the alar base at the end of the procedure. Others would use Surgicel to encourage bone formation. Now the maxillary periosteum is going to be elevated a little bit further. And also released. Periosteum is a non-elastic structure, and you therefore need to release it to allow this mucoperiosteal flap to advance. You're just about seeing the infraorbital nerve there, or the infraorbital foramen at least. That's a little accessory vessel coming through the maxilla at that point, which you need to free. And there's the foramen now, just near that scala. So the periosteum is released by putting it under tension, so that you can easily feel it give, and incising with a knife, firstly laterally in a vertical direction, and then horizontally at a level just below the infraorbital foramen. So firstly and also a little release here of the mucosa, and then a release of the periosteum vertically first, and then transversely, horizontally, just through the periosteum, just below the infraorbital nerve, which is usually seen at this point. Obviously being very careful not to damage the nerve. It's a good idea at this point to put some long-acting local anesthetic around the nerve, in fact doing it perhaps before the nerve is actually exposed. Some bupivacaine, marcaine, which is good for post-operative analgesia. I have to say I don't always remember at the right time, but a good idea. And then the incision continues around to the piriform aperture to become continuous with that release of the lateral nasal wall, so that the periosteum has been incised effectively all the way around. It's important to do that before the vomerine flap is sewn into place, because once it is sewn into place, it's very difficult to get access, certainly obviously to the lateral nasal wall. That incision down the crest of the vomer posteriorly may even extend a little further medially to a little further laterally as a little back cut to free the vomerine flap more posteriorly. I'm just releasing that a little further. This technique works with even the widest cleft, because the hinge point is actually where the vomer angles, and the medial part of the vomer actually is virtually horizontal. So that horizontal part is simply turned back through 180 degrees. Now the stitch here is a vicryl, 5/0 vicryl stitch, and it's on a compound curved needle, and it's a horizontal mattress suture. So through the oral side of the lateral segment, then through the periosteal side of the vomerine flap, back out from periosteal and back out through the oral layer, and it's then pulled under so that there is reasonable overlap. And I then leave those sutures to tie at the end of the when we've put them all in place. So I just push it back. It's if you put an archiforcer on them, they get in the way. So the bites are about probably 5 millimeters wide on the oral mucoperiosteum, through from, if you like, inside out, on the vomerine mucosa, outside in on the vomerine mucosa, I'm sure I'd be told off by health and safety for using my fingers to grab the needle on occasions, and then from inside out on the oral mucoperiosteum. So certainly at this point, even in the widest clefts, it's possible to achieve a good overlap. The most difficult bit is anteriorly, and that's why, as I mentioned earlier, to have enough vomerine mucosa to achieve reasonable closure anteriorly, you need to make this incision on the oral side of the groove of the vomer. We have looked at the 5-year dental arch relationship outcomes of our patients before and after doing the vomerine flap technique. After this technique, only a very small number of patients require lateral releasing Langenbeck flaps at the time of palate repair. So if you compare the earlier pre-1993 technique of no closure of the hard palate at the time of lip repair, and Langenbeck lateral releasing incisions in the majority of palate repairs, versus the post-1993 technique of vomerine flap at lip repair and generally not using lateral releasing incisions at the time of palate repair, the 5-year growth outcome is no worse, and the lateral collapse and lateral crossbite and transverse arch width are all actually better in the vomerine flap group. So To date, we have not found evidence of the bone rind flap being a disadvantage as far as maxillary growth is concerned. But like everything else in clefts, that needs to be a short-term judgment, a temporary judgment, pending long-term follow-up. And it may be that we will see changes that are less favourable, perhaps particularly in terms of vertical growth, and certainly the Gothenburg group, Hans Friede, suggests that may be the outcome. But it's very difficult to make comparisons between teams and between techniques because there are so many subtle differences. So far, it seems to be a very helpful technique. It makes palate repair much easier and less traumatic. It means that you don't have to make lateral releasing incisions in most cases of palate repair. It provides better closure anteriorly, a much lower incidence of alveolar pre- and post-alveolar fistulae, and probably provides a good basis also for alveolar bone grafting, as the nasal floor is largely intact. It adds a little time to the lip repair, and it does increase the discomfort and the blood loss to a degree. And as I said, we've had 4 out of about 160 patients needing to go back to theatre with bleeding, usually from the edge of the incision at the junction of the oral mucosa and the palatal shelf and the voma. It's an unsatisfied edge. There's nothing sutured to it. But tranexamic acid at the time of the repair and post-operatively anecdotally does seem to reduce that risk. So just tying the sutures which have been left there. And what happens is that epithelializes, and in the next tape this same baby will be shown at the time of palate repair, and you will see, if you're viewing that palate repair, that the palatal shelves have narrowed, but more importantly, new epithelium has grown across the undersurface of that voma. And you actually get something for nothing. So it appears. You get neoepithelium. And that neoepithelium can be used as a flap to aid closure of the anterior soft palate. A little posteriorly based V-shaped flap. Sometimes I use a very fine suture, such as fine PDS, as in this case, just to improve the apposition of the oral mucoperiosteal flap to the voma, to increase the area of contact. So it's a very fine 7/0 PDS suture, just sewing the edge of the oral flap down to the periosteum of the vomerine flap, so that the two layers are in contact for all of that overlap. Otherwise, there is a danger that having sutured about 5 millimeters lateral to the margin, that the oral flap will actually sit away from the vomerine flap. That depends on each individual case. Sometimes it lies very well. The vomerine flap, of course, it's very difficult to measure pain in a young child. I don't think that this significantly adds to the discomfort of the baby, apart over the normal discomfort of a lip repair, but of course I can't prove that. It's just an impression of how well the babies recover and when they start feeding and so on. Again, another 7/0 PDS suture just to hold the two flaps in better contact. I'm sure that the secret of success in this technique and of avoiding breakdown and fistulae is that contact between the two flaps over a distance of something like 5 millimeters or more. So it's worthwhile being fairly careful about it. One more pinning down stitch anteriorly. Using a little Stilly's needle holder with without teeth for the fine suture. And trying as always to run the surgical knots down. The microscope's not quite giving the surgeon's eye view. Obviously it's the view that I'm getting doing the operation is slightly different, but it does give a fairly good idea of what I'm seeing. Just make sure that there's no bleeding. One point which is where there often is bleeding is at the very back, where that little back cut has been made, right at the back of the voma. Worth just bipolarizing that area at this stage, if it is bleeding. A little bit troublesome. It would be very nice to use an operating microscope for doing a lip repair routinely, as I do with a palate repair. The argument against using it routinely is that you need to have a much more three-dimensional view of a lip repair. You need to be able to move your position regularly to look at, for example, the nasal correction in different planes. And the microscope doesn't give you that very well. So it does give you very nice magnification and illumination of a muscle dissection, for example, but it doesn't give you that spatial awareness, which I think is important. So I don't personally think that it's particularly useful for a lip repair. I think it's invaluable for a palate repair. Now just continuing that incision that we've made on the edge of the greater segment, the premaxilla, to just finish mobilizing the mucoperichondrial here at this level flap, the anterior end of the vomerine flap. And at this level it's on cartilaginous septum, becoming continuous anteriorly with the C flap. And it would be very easy, if you believe in radical mobilization of the septum, to do it at this stage. I personally don't see the logic of that, in that the septum is attached to the anterior nasal spine. It's the anterior nasal spine and the skeleton that's out of position. To artificially move the distal septum from the anterior nasal spine to a position lateral to it doesn't really seem very logical to me. That's now, you can see the cartilage of the nasal septum. And laterally you can see the lateral nasal wall that we've elevated, and you can see that those two will be sewn together. So at a point at the alveolus, the closure changes. Behind the alveolar cleft, it's vomerine flap interdigitated under oral mucoperiosteum as a two-layered closure. From the alveolar cleft anteriorly, it's vomerine flap sewn end to end to the lateral nasal wall. Now the muscle dissection. The lip is held under tension with a skin hook, usually a fresh 15 blade on the barren handle, and an incision between the skin and the muscle, keeping close to the dermis. And I like to see a white layer on the muscle. And as you get down to the vermilion margin, staying very close to the surface, because the muscle comes at the point of the vermilion margin, the muscle curls around in its J shape and is very close to the surface at that point. So if you're going to get a good inferior muscle repair, you need to, I believe, to be very close to the skin inferiorly. And then deep to the muscle, between the muscle and the mucosa, dissecting in a plane between mucous glands and the muscle. And then dividing the muscle superiorly to rotate it down, dividing it as it curls around upwards towards the anterior nasal spine, dividing that superior attachment. Just continuing that muscle, freeing a little further. And lifting up the C flap, just freeing that a little further as well, up to the cartilaginous septum. And now dissecting around from medially between skin and alar cartilage to carry out the sort of nasal dissection that Harold McComb and Hans Arnold described 30 years ago. So the dissection is between skin and ala. A little way over on the normal side, the non-cleft side also, to allow the alar cartilages to adjust their relative position. I see the nose as something like a three-ply structure with a thin mucosa closely attached to the middle layer of cartilage, and then a much thicker skin and subcutaneous layer. I think that it's unwise to separate mucosa from alar cartilage, but separating the thick skin from the cartilage allows the layers to adjust themselves, and when we're correcting the nose, I think it increases the degree of symmetry which you can achieve, improves the symmetry. And you can see that having carried out that release of the lateral nasal wall and the release of the anterior maxillary periosteum, that the lateral segment comes into position, the alar base comes up into position now easily without tension. You can see that lateral nasal wall. Now it's possible to adjust the length. If you need a bit of extra length laterally, you can simply take the incision a little further laterally, create a new little triangular flap, excise the previous one, and just get a little extra length. And I've decided here that the lateral element is a little short, shorter than the corresponding part of the medial element. If you need to lengthen the medial element of the lip, then you have to do it by going further over towards the non-cleft side. I like not to go past the column of the philtrum, but that's not usually necessary. If you do go past the opposite column of the philtrum, you're actually no longer lengthening the cleft side compared with the non-cleft side. You're actually lengthening both. I don't personally use back cuts on the medial side. So this is just defining the little triangular flap. The new triangular flap. Trimming a little mucosa away also. And now once again the muscle dissection. Sharp blade in a plane, leaving a little subdermal tissue on the muscle so that you leave a thin white layer on the muscle, just because you want to make sure that you keep all of the muscle, and that little white layer provides you with some strength to the repair when it has to be sutured. It's a plane that's fairly easy to find. But once again, as you get down towards the margin, towards the triangular flap and then the vermilion margin, becoming even closer to the skin, because that's where the muscle lies. So that's the inferior part of the dissection. Curling around and extending perhaps 3 or 4 millimeters. And then on the mucosal side, a plane between the mucous glands and the muscle, which is usually very easy to see. But curling around, using the curve of the round barren handle to curl around the lip margin. You can see that the muscle is still attached superiorly near the alar base. So that is now detached. Again, as we did medially, to rotate that muscle downwards, detach it from its position, inserting it up towards the alar base and rotate it down. You do need to go quite a long way laterally at this superior end of the lateral dissection, not as radically on the medial dissection. And now carrying out the nasal dissection from laterally, so going up from the alar margin, finding the plane between the skin and the alar cartilage. And it's much easier to actually find that plane from medially. We've already done that. It should now be possible just to meet up with the dissection we've carried out from medially. So again, dissecting skin off the alar cartilage. Obviously being very, very careful not to perforate either most importantly the skin, but also the nasal mucosa. And then lifting up the dome of the alar cartilage, pulling the alar base into position and seeing how well we've achieved correction. And trying to get a feel for what the nose is going to look like. I prefer on the whole to use a swab to get rid of any blood rather than a sucker, which just tends to encourage it. There's our little bone graft going in, which may or may not be worth doing from the bone graft from the turbinate. Now, continuing with the closure of the nasal floor. The first stitch is usually a three-way stitch. At the point where we've stopped being able to put the vomerine flap under the oral mucoperiosteum. So going through the vomerine flap, through the alveolar margin, and through the lateral nasal wall. That is obviously the most vulnerable point as far as fistula is concerned. usually using Vicryl, 5-0 Vicryl, just because it's going to stay around for quite a long time, and this is a single layered closure. So the idea is to try to produce a watertight closure at that point. But I suspect that if you look carefully in that alveolar area in the future, that a number of these patients will actually have a fissure at that point. But it should be a small one and asymptomatic and able to be closed at the time of alveolar bone grafting. So as the nasal floor is closed, it's important to make sure that the lateral nasal wall is continually brought forward so that the alar base can be positioned in the right place without tension. So you need to be constantly checking that you're not tethering the lateral nasal wall back. These sutures are generally knotted on the superior side, in other words, in the nasal floor, and often an ordinary vertical mattress to try to get good apposition. The compound curved needle gives nice exposure. It's very useful for this part of the repair. So I think you can see we're not tethering the lateral nasal wall or the alar base backwards. So this is a mattress, a vertical mattress suture, just to produce some eversion up into the nasal floor. A little bit fiddly, but I think it's worth getting a couple of mattress sutures in here if you can. Otherwise they tend to invert. And again, just checking that the alar base is going to come up into position. It's possible to overcorrect that forward displacement of the alar base, and I think that increases the web that remains a problem in the vestibule. So shouldn't be overcorrected. So that closure of the nasal floor comes forwards basically to the back of to the base of the C-flap. We're almost forwards to the alar base. Each stitch you put in should make the nose more symmetrical. And then the mucosa. And I think it's quite important to bring the mucosa over to the lateral mucosa over to the premaxilla, and to put it in under a bit of tension. One of the things that can happen after a vomerine flap is that the lip gets almost sucked down as the defect contracts. It can pull the lip mucosa down into the cleft. I've seen that on a number of occasions. The child looks flat in this area. So the idea to try and prevent that happening is to make sure that the mucosa is fairly tight across the alveolar margin. In other words, can't be pulled down very easily. If that does happen, then it's very worthwhile just to, as a relatively small procedure, to free the mucosa up from the alveolar cleft. So the mucosa is now sewn to the mucosa of the greater segment up near the sulcus. And now continuing with some superior mucosal stitches. I don't try to close the mucosa in the sulcus as it crosses the alveolar gap. I think it's actually a good thing to have a place for blood to be able to escape from the lip. And I think you get a much less hematoma formation actually in a complete cleft like this than in an incomplete cleft where there may be a closed space. Now this is a nylon alar base stitch inserted first through the lip below the anteronasal spine and then through the alar base. This is 4/0 nylon, making sure that the knot is going to be deep. If it's not to the anteronasal spine, if you put it to the anteronasal spine, it'll be too high. It's at a point below the anteronasal spine on the premaxilla, just so it's deeply near the premaxilla, but below the anteronasal spine. And I think that's a very important stitch. And I'll often take it out and reinsert it because it's not quite what I want. And I'll sometimes put in more than one if one doesn't correct. But in this case we seem to have produced reasonable symmetry of the nostrils. The view that you're getting through the microscope is a slightly more inferior view than the view that I'm getting, operating just near the objective of the microscope. For a nylon, because I want something which is reliable, which is not going to disappear. And that's exactly what I'm doing here. I'm repositioning it because I wasn't happy. The stitch is going through I suppose the deep muscle over the premaxilla. And then through the tissue at the alar base. if you believe that the nasalis or the motafilmus is very important, this is probably repositioning that muscle, but not trying to dissect it out as a separate layer, and taking fairly strong bites. I think that has improved the symmetry a little further. You don't want to go too far across the midline, otherwise you actually distort the other nostril. I like nylon because it's non-reactive, it's monofilament, it's not braided, it's reliable, you absolutely know it's going to stay there long enough. It doesn't seem to cause any problems. I've had very little problem with buried nylon sutures, which I use for both the sailor base stitch and also for muscle repair. Okay, the next thing then is to repair the mucosa, and I used to be rather careless about the mucosal suture, but I think it is actually important. So the first thing I do is I put a stay stitch through the lower margin of the lip, through the mucosa, making sure that on each side of the cleft it's at an equal distance from the vermilion margin. And then put a clip on each end of that, an artery forceps on each end of that, and use that to position the stitches at a higher level, the remaining mucosal stitches, making sure that the medial and lateral mucosa is accurately aligned. If the lateral mucosa is low in relation to the medial mucosa, you tend to get a lip which is bulging on the cleft side. The other way around, you can get a lip which is thin on the cleft side. I think it's one of the reasons for that sort of discrepancy, although the other reason is to do with the muscle repair. Here we're also just making sure that we're at an equal distance from that marginal stay stitch. By putting the marginal stay stitch on two separate artery forceps, it's the edges are not held together, but the positioning can be corrected. Now, having completed the mucosal suture, we're repairing the muscle, and this is using Thibo nylon, knots buried deeply, beginning inferiorly with that muscle that we've carefully dissected out by staying very close to the mucosa. And I think getting that inferior muscle right is very important in avoiding notching, shortening. And the suture is an overlapping suture from overlapping the lateral muscle over the medial muscle. In other words, starting deeply medially, deep to superficial, then deep to superficial laterally, superficial to deep laterally, superficial to deep medially, so that the lateral muscle will overlap the medial muscle. And the idea of that is firstly to produce a solid repair, because end-to-end muscle sutures are not particularly strong, and secondly to produce a ridge which will simulate the filtral column on the non-cleft side. And I'm very happy to replace that stitch if it doesn't look right, because if you don't get the alignment right, there'll be a mismatch at the vermilion margin. It's not possible to repair the skin accurately if the muscle's not accurate. So I've taken it out and I'm putting it back in again. Often there appears to be more muscle laterally than medially. In other words, that you're right at the margin of the muscle medially, but a little above the margin laterally to get it accurately aligned. That may be something to do with how far down the muscle rotates following the superior release. So the horizontal mattress suture. Trying not to handle this tissue with tooth forceps, but using, in this case, a skin hook to retract the skin. And no doubt illegally offending some bylaw, some rule somewhere, using the fingers to grab the needle. But that looks right. So we'll put a clip on that and put all these sutures in, usually before tying any of them. Usually about 5 or 6 muscle stitches. Deep to superficial, medially, deep to superficial laterally, I mentioned earlier why I sacrifice a certain amount of mucosa in the planning stage, and the reason for that is that I think with this overlapping of the muscle, it's easy to produce redundant mucosa, so that you need to account for that. And I must say a lot of my patients do end up with a little bulge of the mucosa at the stitch line, which can be a nuisance, a bit unsightly, can produce a little minor deformity of the teeth in that area, and which we do end up trimming on occasion. So I've become a little more radical in what I excise. So here we're putting a stitch above as well as a stitch below, and then we can get the alignment of the remaining muscle stitches accurately. If tooth forceps are being used, then use very gently just on the surface of the muscle. So again, deep to superficial, deep to superficial, superficial to deep, superficial to deep. And I have to say I'm pleased with this particular aspect of the technique. The recreation of the filtral column does seem to be fairly effective. Trying to avoid getting in a tangle here. Another muscle stitch. What you're trying to do is to produce a rather tighter repair superiorly than inferiorly, so that you get nice eversion of the lower part of the lip. One of the other many advantages of using non-absorbable nylon for these crucial stitches, such as muscle stitches, is that if you do have to go back in later, you find it. Never any reaction around it, but you know where you've been. It's a nice landmark. I think the muscle repair is the most important part of probably the most important part of the whole lip repair. Producing a nice tension-free and strong muscle repair, having rotated it down, which I think is very important to achieve adequate length of the lip. So many lip repairs look reasonably satisfactory on the still view, but when the patient smiles and speaks and purses the lips, it's much less satisfactory. Some surgeons separate the orbicularis into its various components, but I don't. I think the important thing is to repair it with a good, strong repair. These knots are deep and not tied too tightly. And that's really the most important part of this operation done. Parents always think that the skin stitches are very important, but they're about the least important. And finally, tying the inferior marginal muscle suture. Trying to tie some decent surgeon's knots. Running them down accurately, not leaving too much suture material. I always make a point of cutting the non-absorbable sutures myself, cutting the ends, because of wanting to avoid any long suture ends. Now, having put those 4 sutures in, I'm going to put a 5th stitch at the upper end, just to tie that superior muscle up towards the anterior nasal spine area, but not right up to the anterior nasal spine. We don't really want to fix the muscle to any fixed points. The lip needs to be mobile from side to side. Even at the level of the base of the membranous septum, there's mobility. That one's not an overlapping horizontal mattress stitch, but a single suture. Bit of a clean-up prior to the skin suture. I've put the 2 marginal mucosal stitches now on one artery forcep, and that just puts a little tension on and just gets the alignment right. Using 8-0 ethylon, which I think is sufficiently strong for the skin repair. The alternative would be, if I didn't have that available, I'd probably use something like 7-0 Proline. I think 6-0, the standard skin suture, is really too bulky and the needle too big for this fine suturing, not using the forceps here to actually grab the skin. So the first stitch is going in at the previously tattooed mark at the vermilion margin, just at the lower end of the little triangular flap and the inset medially. And all of these skin stitches I try to place everting stitches, stitches which take more dermis than epidermis. Using a skin hook to do it helps a lot, because you can actually evert the skin with the hook. And again, not too tightly. And then either putting in the little triangular suture or the suture at the top as the next one, and using an angle suture through the dermis of the advancement flap. As you can see, the incision there, the medial incision, has gone just across the midline, but not to the opposite column of the philtrum. And that suture should be should be possible to close that flap with minimal tension. And now the small triangular flap into the incision, which I make it approximately at right angles to the vermilion margin. It may be that you get a little more lengthening if you make it a little more transversely. Picking up just the dermis of the tip of the triangular flap. This is a nice little needle for a baby's skin. It wouldn't be very good for a tough adult skin, but it's nice for a baby skin. This repair is being carried out at 3 months, and the palate repair will be performed at 6 months, by which time that bone marrow flap should have well epithelialized. There was a vogue for neonatal lip repair in the UK, but it's largely gone out of favour, with no evidence of better results, and I think some evidence of less satisfactory results as far as growth is concerned, and no benefit as far as can be seen for scarring. Another little angle stitch through the dermis. And I think you just have to handle that needle by hand. It's too small and fiddly to do everything by instrument, but obviously taking care not to prick yourself. It's very tempting to use absorbable sutures, something like 7/0 Vicryl Rapide. I have used it. I've used it in other countries when I'm not going to be around for suture removal. I'm just not totally happy about its duration of action, and the amount of tissue reaction that it produces. Wait to be convinced. It would certainly be nice to use it if possible. We don't routinely give anesthetics, general anesthetics for suture removal. In one half of our centre, the patients do on the whole have general anesthetics, and the other half at Great Ormond Street they don't. They have sedation on the ward. So at the St Andrews Centre, sedation and a general anaesthetic, and at Great Ormond Street not. It's perhaps just a question of the expertise around for sedation. But undoubtedly removal of sutures is quite a difficult and demanding procedure in these small babies. And if there's a non-absorbable suture, an absorbable suture which is as good as this fine nylon, it'd be very nice to use it. Our babies feed normally. We do not use arm splints. We've shown in a little randomized trial in palate repair that arm splints are not necessary, that there's no increase in fistula formation if they are not used. And similarly for lips, I'm not concerned about the babies damaging the lips. As soon as this local anaesthetic wears off, they're not stupid. They realise that very soon that it hurts if they start pulling their lip around. But they feed normally by bottle if they've been bottle feeding, by breast if they've been breastfeeding, particularly lip-only patients. None of our babies spoon-fed or beaker-fed. Trying with these stitches to evert as much as possible. Obviously, they need adequate sedation and analgesia, adequate analgesia on the ward. As far as antibiotic cover is concerned, we give them penicillin V as an anti-beta hemolytic streptococcus agent. It may not be very logical. The alternative is to take swabs from all of them and only treat those that have positive swabs. Trouble is that beta hemolytic streptococcus is quite difficult to culture, and it's the one organism that I think that I'm worried about that can actually potentially disrupt a lip or a palate repair. So we give some IV crystalline penicillin at the time, benzoyl penicillin at the time of induction, and then usually oral penicillin V elixir for up to 5 days post-operatively. Now a suture, an angle suture through the C-flap, again picking up the dermis. Trying not to get in a tangle, and just making sure that that little C-flap forms really not, well, partially the nostril sill, but also the foot plate of or something that simulates the foot plate of the medial crus. In doing an open rhinoplasty later on patients with these who've had a C-flap, I may well re-raise it and then close that defect as a V to Y, as a way of lengthening the columella on the cleft side. And with this suture, trying to pick up a little bit more thickness of dermis on the skin flap than on the C-flap. just as a way of getting it out of the way. We don't want it to be obtrusive. So that's the skin closed, hopefully with no significant tension. A little vicryl, or actually this is 6/0 monocryl, I think, stitch in the nostril floor to hold the posterior border of the C flap down and to unite it to the lateral nasal wall, just to stop it bunching up into the floor of the nostril. Again, quite an important little stitch, I think. Not necessarily trying to make that skin closure too watertight. Now, what to do to the mucosa? I do a Z-plasty. Sam Nordhoff does a V flap from laterally to medially. Both, I think, achieve probably the same thing, which is to align, firstly, to avoid a straight line scar which is likely to groove. Often that stay stitch, by the way, needs to come out at this stage. And secondly, to align the wet-dry junction, because the wet-dry junction is going to be more posterior on the lateral cleft side than it is on the medial non-cleft side. So the Z takes that into account. It's more posterior on the lateral side and more anterior on the medial side. And when those flaps are transposed, the wet-dry junction is hopefully aligned. And at the same time, the straight line scar avoided. I don't cut with scissors very often, but this is one place where scissors are useful, just to cut that little V flap or Z flap. And then using generally 7/0 vicryl repeat as the suture material for the more visible part of the mucosa, to avoid stitches which stay in too long and leave white stitch marks in the pink vermilion. Not in this case doing the angle sutures, but just a standard per mucosal stitch. I think you can see that the mucosal repair has been important there, and it seems to produce about an equal amount of vermilion show on the cleft as on the non-cleft side. So that little Z-plasty does seem to largely get rid of the tendency to notching or grooving at that point. Our patients stay in hospital usually for 2 days post-operatively for pain relief, just to make sure that feeding is established, and then they come back on the 5th day for removal of the sutures. This baby has not had pre-surgical orthopedics. We've carried out a trial, having personally been in favour of pre-surgical orthopedics, at least for wide unilateral cleft lip and palate patients, but we have failed to show any objective evidence of benefit. There may be subtle reasons why it's or subtle benefits, but we haven't been able to show them, certainly in terms of feeding or significant benefits for speech. Again, just to stitch in that, to sew that little C-flap into position in the floor of the nostril. We do, incidentally, use pre-surgical orthopedics for wide bilateral clefts. The jury is still out, but we haven't found any evidence so far of benefit. I used to carry out supporting sutures to the domes of the alar cartilages a la Harold McComb. Unlike him, putting them in at the end of the procedure, not early on, because I found they got in the way of it, to be honest, but and then tying them over bolsters. The problem with that is that you take those bolsters away at 5 days, and somehow they often seem to slump, although he seems to manage to do it. So instead now I use this technique. I use a blue needle. I call it the sewing machine or the upholstery stitch. It's a buried stitch using 5/0 PDS, which presumably remains in place for about 3 months or so. Certainly it's still there often at the time that we do the palate repair. And it's put in through the skin of the nose, out through the lining, then the PDS is threaded up through the needle. The needle is then withdrawn till it's almost out of the skin, picks up some deep tissue at a high level, and goes back through a different route, back out through the mucosa, so that it's anchored superiorly. Now in this case we're putting the stitch first to hold the web out. The actual alar dome here seems to be in pretty good position, but I will often put a stitch high on the bridge of the nose to near the rim, to lift up the rim and to lift up the dome. But here the main problem seemed to be that web, and so I'm putting that somewhat more lateral stitch and tying it so that the web lifts up towards the nasal bones, and that's 5/0 PDS. So I'll put as many of those in as necessary. Sometimes one for the rim, one for the web, sometimes one at the alar base. It just depends where they're needed. And occasionally I'll do a percutaneous stitch, go from inside the nose out, back through virtually the same hole, and then through a different route subcutaneously. Just checking that the web is adequately corrected. The rim seems fairly symmetrical, and the domes also seem fairly symmetrical, so there's no need for any more of those sutures at that point, but the technique is the same. The positioning of the stitch is somewhat different. And lastly, remembering to take the pack out after cleaning up a little. And also remembering not to pull the anaesthetist tube out in the process. And it's worth just rechecking that there's no active bleeding there. You can see there's been a little trickling of blood from the vomerine flap. So now it's wait for 3 months for the final repair of the palate.